I'm the co-chair of Holland & Hart's Healthcare Group. Welcome today to our regular Monday afternoon update of COVID-19 legal issues for the healthcare industry. I'm joined today by my partners Tim Crisp, Brian Bernard, and Jay DeVoy. Tim's going to talk first about the stimulus package that came out late last week. I'll take a few minutes and talk about the Provider Relief Fund and some of the other targeted disbursements that are being made. Brian's going to come on and talk about some of the recent guidance we've received from the EEOC. And Jay will conclude by talking about some fraud and abuse type issues. Tim, if you wouldn't mind starting us out and letting us know a little bit about the additional money that came out last week.
Will do, Kim. Thanks very much, and good afternoon, everyone. I'm going to be talking primarily about the Paycheck Protection Program, which I addressed in a webinar here for this group about 2 weeks ago. So I'll give you a little bit of a recap for those of you who weren't able to attend, as well as some updates on some important developments. The PPP, as you may recall or may have read or heard on media, is a loan program that is being administered and guaranteed by the U.S. Small Business Administration. They're loans that are made directly by banks or credit unions or other SBA partner lenders to small businesses. And it's a nice program in that it's intended that at least 3/4 of the program has to go to eligible payroll costs. The remaining 25 can either be used for those costs as well as a few other things such as rent, mortgage interest, and utility service payments. Based on the spending of those funds on those things, as well as rehiring or retaining employees during the 8 weeks after funding, an eligible business that borrows under this program could be eligible for up to full loan forgiveness. To the extent that it wouldn't be forgiven, it's repayable over the next 2 years at 1% interest with all payments deferred for the first 6 months. No collateral, no guarantees, anything like that. Initially, when the CARES Act was first passed on March 27th, Congress had appropriated $349 billion with a B dollars for the Paycheck Protection Program, as well as additional administrative funds to help the SBA process those applications. Those funds first became available the following Friday, and they became completely accounted for and depleted within about 10 days after the first applications were accepted by the SBA. This is a program, as you may have experienced yourself or may have been reading or hearing about, that had many problems from the outset. Banks were confused, borrowers were confused. The SBA was certainly confused and has had to issue multiple guidances along the way. But long story short, a number of borrowers were able to access these funds and get their applications approved and funded. A great many more were not. And so that left a tremendous demand. In part, these were businesses that the banks didn't figure out in time, or maybe put them further back in queue, and so they just weren't able to get in line far enough up to get that first $349 billion. Now, as of this last week, there has been a Paycheck Protection Program extension program that Congress passed and the President signed into law that reappropriates an additional $320 billion in funds for paycheck protection loans and loan guarantees. The SBA first started accepting applications and processing applications under this new appropriation this morning. It's expected that, again, there's going to be tremendous demand. A few kind of key developments here. Unlike the initial appropriation and the initial CARES Act, Congress recognized that a large number of the amount of the initial loans were being made through some of the country's largest banks who were preferring some of their largest customers, even though they were supposed to be small business customers. And so Congress attempted to remedy that this time around by earmarking $60 billion out of the $320 billion, so a little under 20% of the total appropriation, is going to be reserved for smaller banks. So I say that in part because this means that you may have a much better shot if you were looking to apply for these funds. You didn't get funding in the last time around. You may have a better shot applying through a community bank or other smaller bank than going through one of the big national banks. One question I've been getting in recent days with the new appropriation from folks who may have gotten a loan already under the PPP program is, I'm excited, I got my funding, can I apply for a new PPP loan now that additional funds have been reappropriated? And the answer is no, you can't. The program is limited to one loan per customer. So if you were one of the fortunate ones to get a loan processed, approved, and disbursed in the last go-round, count yourself among the lucky. And for those of you who didn't and who are still interested, I would recommend that you talk with your bank very, very soon. There's some complicated rules on affiliation and determining whether you were an eligible small business. So between you, your banker, and certainly those of us at Holland & Hart have been advising a number of businesses on how and whether they can qualify for these loans. Now, I'd like to bring up a new topic, and this is something that just came up for the first time this last Thursday, that may give you pause if you've already taken out a loan, or it may give you even more pause if you haven't yet taken out a loan but are otherwise interested in this program. The SBA, in consultation with the Treasury Department, issued some guidance which has the effect of a formal interpretation of the law by the SBA last Thursday. And they asked, and specifically, do businesses owned by large companies with adequate sources of liquidity to support the business's ongoing operations qualify for a PPP loan? Well, those of us who have been following the PPP in the press have probably read plenty of stories and reports over the last week about some larger companies, particularly in the restaurant industry and the auto industry, applying for these loans, but that by all appearances seem to be very, very large companies. Publicly traded companies like Shake Shack, the parent company of Ruth's Chris Steakhouse, and the auto nationwide auto dealership AutoZone, among others. And one question that I've gotten from a number of people is, well, how could they do that? They're clearly not small businesses. The answer is apparently those industries had much better lobbies than the rest of us did, because in the initial CARES Act, they were able to secure different terms. So the general limit of no more than 500 employees for a small business does not apply to them. It's limited to 500 employees per physical location, but it could be a much larger business. That being said, there was a lot of public outrage and political outcry over the fact that these large businesses were taking taxpayer funds on this extremely favorable loan program when they could get their money elsewhere. And so this question was posed to the SBA, whether such businesses that have ample capital and are large can get a PPP loan. The SBA answered that they do not qualify. They are not eligible borrowers. But then they went further than that to make broad sweeping statements that basically apply to all businesses that have a loan, PPP loan, or are considering applying to one. Specifically, the SBA wrote that all borrowers must assess their economic need for a PPP loan under the standards established by the CARES Act and the PPP regulations, and specifically that borrowers have to certify in good faith that their PPP loan request is necessary. SBA gave guidance that all borrowers need to carefully review that certification that current economic uncertainty makes the loan necessary to support their ongoing operations, and added that they now need to take into account their current business activity and their ability to access other sources of liquidity sufficient to support their ongoing operations in a manner that's not significantly detrimental to their business. Now, much has been written and said among thought leaders on the PPP and small business loans in the days since this has come. In a sense, this new guidance kind of turns the CARES Act provision that got rid of the needs test and the requirement that you can't get funds elsewhere on its head. Congress decided that businesses don't need to prove that they can't get the funds elsewhere. Now the SBA is saying you shouldn't be applying for a PPP loan if, for example, you can tap your line of credit, you can tap other financing sources, you can get funds from a parent company or supporting organization. So this guidance, in short, has created a lot of anxiety among existing borrowers as well as prospective borrowers. For those businesses that have taken out a loan before this guidance came out last Thursday, the SBA has issued an edict that those borrowers can repay the loan in full by May 7th, and they will be deemed by the SBA not to have violated that certification. For those who are new applicants or new borrowers after last Thursday, it's important that hospitals and other businesses take a careful look, and I would recommend documenting at the board level the consideration of these factors and whether you have other sources of liquidity and whether you need this loan to support your ongoing business needs and payroll. If you fail to do that, the SBA has clearly signaled that they will be auditing files, presumably when requests come in for loan forgiveness, but also they're probably going to be doing it on a randomized basis. Clearly, the intent here was to get rid of the big businesses that are, basically taking all the funds that were intended for small business to themselves, and that drained those funds, at least initially. But I think that the SBA kind of went after a fly with a sledgehammer here. And as a result of this, unless and until there's new guidance that comes out that clarifies this or backpedals somewhat, borrowers and applicants on the program, unless they are truly small and truly in dire financial circumstances, may have a hard time justifying that. So that's this week's update on the Paycheck Protection Program. And with that, I'll turn it back to Kim.
Thank you, Tim. One additional issue with regard to the PPP, it now appears that the PPP is available to at least some public hospitals. There was a question about that, or actually in the past, it wasn't available for government hospitals, but it looks like that has changed. There was an interim final rule that issued last week. As part of that interim final rule, they include certain questions. One of those questions is a hospital owned by a governmental entity eligible for a PPP loan? And the answer was a hospital that is otherwise eligible to receive a PPP loan as a business concern or nonprofit organization described in Section 501c3 of the Internal Revenue Code and exempt from taxation under Section 501a of the Code shall not be rendered ineligible for a PPP loan due to ownership by a state or local government if the hospital receives less than 50% of its funding from state or local government sources exclusive of Medicaid. The administrator, in consultation with the secretary, determined that this is an exception that would apply to the otherwise prohibition on government-owned entities. So if you are a government hospital, then you may be able to actually participate in that PPP loan program that you thought you were excluded from. Remember that the other terms and conditions apply, including it has to be less than 500 employees generally. In addition, note that the PPP loan program is only available until the funds are exhausted. So if you want to participate in that, you need to get to the trough sooner rather than later. As part of that overall stimulus package, where the government had appropriated more funds for the PPP program, they appropriated an additional $75 billion, that's billion, for hospitals. But I at least have not seen how that is going to be distributed yet. So we'll have to watch for that. That should be coming down pretty shortly. But again, another $75 billion for hospitals. They also appropriated $25 billion for testing. The other big news on the relief package was the second round of the Provider Relief Fund payments that began going out last Friday. There's different types of fundings, different types of programs under that Provider Relief Fund. The first is the general distribution that goes out to all providers who participated in Medicare in 2019. We got the first round of that a couple of weeks ago. That was the $30 billion that went out based on your Medicare fee-for-service amounts back in 2019. This second round of $20 billion went out, and it's based on the patient revenue from 2018. The second round, the $20 billion, is designed so that it brings the entire $50 billion, including the $30 billion that went out last time, so that the overall funding that you got was based on the 2018 patient revenue. In order to participate in those funds, after January 31st, 2020, you had to provide or provided diagnosis, testing, or care for individuals with possible or actual cases of COVID-19. As we talked about in the past, there was some uncertainty about whether or not entities that may not have specialized, maybe they were specialists, maybe they didn't treat COVID-19, but they otherwise treated patients or residents, were they able to participate and retain those funds? We haven't got a whole lot of clarification other than the government still seems to stick to its position that HHS broadly views every patient as a possible case of COVID-19. So if you are providing care to patients with possible COVID-19 back after January 31st, 2020, then it looks like you'll be able to keep those funds. Now, the rules for keeping those funds seem to be changing relatively quickly. As part of receiving those funds, you had to attest, or you will have to attest, and those attestations, the terms and conditions for those attestations changed twice last week. On Saturday, they published new FAQs that are available at the government's website, hhs.gov coronavirus/CARES Act Provider Relief Fund. If you just Google HHS Provider Relief Fund, that'll take you to the website, and it contains updated terms and conditions. It contains the FAQs and updated guidance from the government on those items. Among other things, they have confirmed that this additional $20 billion that went out is only available to those who have received the Provider Relief Fund payments by 5 o'clock p.m. Eastern Standard Time on Friday, April 24th. Some received those automatically. Some received those payments, the additional $20 billion in payments, if CMS had adequate information from their prior cost reports. You are still going to be required to submit information to the government through the portals at that website concerning your revenue in order to verify the patient revenue so that you can retain that money. Now, others for whom the government did not have sufficient patient data on file, they're going to have to go to that website and they've got to submit their revenue information through the general distribution portal. That general fund application portal that they have to use is collecting 4 pieces of information for use in allocating those additional funds. You're going to have to submit information concerning your gross receipts or sales or program service revenue that's listed in your federal income tax return. You're going to have to provide your estimated total revenue losses in March and April 2020 due to COVID-19. In the FAQs that came out said that you may use a reasonable method of estimating the revenue during March and April compared to the same period had COVID-19 not appeared. For example, if you have a budget prepared without taking into account the impact of COVID-19, the estimated lost revenue could be the difference between your budgeted revenue and your actual revenue. It would also be reasonable to compare the revenues to the same period last year. So in some way, somehow, you're going to have a reasonable method for estimating your losses. You're also going to have to provide a copy of the provider's most recent federal income tax return and the tax identification numbers of subsidiary organizations that have received relief funds but do not file a separate tax return. You've got to, in addition to submitting those applications or that additional information, again, you're going to have to attest and agree to the terms and conditions through the attestation portal before you can apply for these additional funds. As far as the payments going out, as I mentioned, some of you have already received those payments. For providers that are submitting the tax and financial information, HHS intends to distribute additional funds within the next 10 business days. The funds will then go out on a weekly basis based on the information being validated. Now, in the FAQs, the government says that the funds are not disbursed on a first-come, first-served basis, so it's not like the PPP. And instead, they've attested that the applicant will be given equal consideration regardless of when they apply. Be that as it may, I would still recommend to my clients that you get in line and you submit that information as quickly as possible if you have received that money. Now, this is only available to those who have received some portion of the Provider Relief Fund, that $50 billion general distribution. If you have not received any of that money yet, then you're out of luck because the government specifically said that providers who have not yet received any payment from the Provider Relief Fund should not use the general distribution portal. However, you can't, so you're not going to be able to get the general distribution. However, you can still apply for some of the other targeted distributions I'll talk about in just a minute. In the FAQs, the government emphasized that if you think that the government made a mistake, well, you really don't have any recourse, at least through the administrative process. They said that HHS is not taking any calls and there is no remedy or appeal process for the distribution of those general funds. All right, so let's assume then that you missed out on the general funds, you weren't able to get that. The government still has a number of targeted distributions that are aimed at providers who did not receive those general distributions or who were disproportionately impacted. All providers retaining funds, just like under the $50 billion general distribution, they're going to have to sign an attestation and accept the terms and conditions associated with the payment. They're also going to have to submit tax documents and financial loss estimates if they wish to be eligible for any of the additional funds. The first $10 billion went to hospitals in high COVID-19 areas such as New York. Those entities that were eligible for those funds should have received an email and they were required to apply to those. The initial deadline was last Thursday. That was extended to Saturday at 5:00 p.m. Eastern time, I believe it was. So most of you are not going to be eligible for that. There is an additional $10 billion for rural hospitals and RHCs that is supposed to be distributed over this next week, and the payment process is going to be based on operating expenses. Now, we don't have a lot of more details, so stay tuned on that one. This additional $10 billion for rural hospitals and RHCs is different than the $165 million that was awarded through HRSA last week. I'll talk about that more in a minute. There is also going to be an additional allocation for testing and treating uninsured for COVID-19. This is actually going to be administered through HRSA. The new website was created last week for this program. It's HRSA.gov/COVID uninsured claim. So if you want to access that website that has the terms and conditions and the application process, you go to that website. Generally, under this program, you'll be paid at Medicare rates subject to available funding. So once more, if the funds are depleted, then you're out of luck. So you're going to want to submit those claims as soon as possible. You're going to be paid on a first-come, first-served basis. It applies to providers who rendered tests or treatment of COVID-19 for uninsured patients after February 4th, 2020. In order to participate, you've got to enroll in the program and provide certain information. Among other things, you're going to have to attest that you have checked with for the patient's health care coverage eligibility and confirmed that they are uninsured, that you have verified that the patient does not have individual employer-sponsored Medicare or Medicaid coverage and no other payer will reimburse you for the COVID-19 testing and or care for that patient. You're going to have to attest that you will accept defined program reimbursement as payment in full, so no balance billing, and you're going to have to agree to the program terms and conditions and may be subject to post-reimbursement audit review. We don't have all those terms and conditions yet. As far as the timeline, the sign up to participate in this program begins today. So again, you go to the website and you can access that and go ahead and enroll. On April 29th, there will be on-demand training, which will start. On May 6th, you can begin submitting the claims electronically. The website describes the coverage, the CPT codes associated with the claims, and what they will pay. In mid-May, you should begin receiving the reimbursement. Again, you can't balance bill the patients for the COVID-19 treatment as part of those conditions. There's an additional target distribution of $400 million to the Indian Health Service, and there's going to be additional funding in the future for facilities that solely take Medicaid, so they weren't able to participate in the general disbursement, such as some nursing facilities, dentists, et cetera. So again, stay tuned on those issues. Now, with all of these programs under the Provider Relief Fund, the government has stressed and have updated the terms and conditions to reinforce that fraud and abuse, applies here. And the government is going to be doing auditing. You're going to be required to submit certain reports, and if they are found that you have inaccurately documented or claimed funds to which you were not obligated to, were not eligible to receive, that you're going to have to do a repayment, and that could subject you to False Claims Act penalties or other claims. That is the General Provider Relief Fund. Last week, the government also announced that there are additional funds for rural communities. On April 22nd, HHS and HRSA awarded $165 million to rural hospitals to be used for the expansion of telehealth, for the purchase of PPE, and for blood testing. We anticipate the guidance concerning that to come out shortly. I haven't seen the specifics on exactly how and when that is going to fund. Just real quickly, before I turn the time over to Brian, I just wanted to mention that last week Christy talked about reopening and some of the considerations for those of you who want to reopen some of your facilities. Last week, CMS issued reopening guidance to provide some additional direction if you want to reopen. That guidance was issued on April 19th. It's found on the government's website. It's basically goes off of President Trump's gating criteria and that phased approach. The gating criteria, of course, requires a downward trend for 14 days in symptoms and the like of COVID-19. In addition, the hospitals have to be able to treat all patients without crisis care and have a robust testing program in place. The recommendations address such things as the maximum use of telehealth technologies, general considerations for resuming non-COVID care, personal protective equipment, workforce availability, facility considerations, sanitation protocols, supplies, and testing capacity. So if you are in those fortunate states that are looking at reopening, you may want to look at that CMS guidance in addition to the joint statement that was issued by the American College of Surgeons and others as you try to work in your reopening plan. With that said, I'll turn the time over to Brian to talk about some EEOC issues.
All right, thanks, Kim. So that's a great segue as we start looking at reopening business and work sites. And on, the 23rd of April, which was just late last week, the EEOC once again updated its advice related to what employers can do in the workplace with respect to testing of employees. And so it's really the balance here and kind of the angle we're coming at is the Americans with Disabilities Act has always considered something like taking an employee's temperature as a medical examination. And those are generally prohibited unless they are job-related or related to understanding if the employee is able to perform or is a direct threat to the health and safety of those around this employee or to the public. Now, in that context, the EEOC and in COVID has been really relaxing some of these standards in a sense, which is quite surprising and unusual. What they have done is, prior to last week, they said that employers can ask if an employee has COVID-19 symptoms. And if they do, they can send the employee home. They also indicated that if an employee had been tested and diagnosed with COVID-19, separately from what the employer did, and that is disclosed to the employer, that the employer could require a fitness for duty return to work medical certification. What changed last week is very interesting because the EEOC now has come out and really the type of things that the employer can ask about. So in addition to asking if an employee is symptomatic, they also have now expanded this that they can ask for any of the COVID-19 symptoms as outlined by the CDC. And so that includes some new ones, including, chills, muscle pain, headache, sore throat, loss or taste of smell, those types of things. So the inquiry that employers can make to their employees has significantly increased based on this latest guidance from last week. Now, the other piece to this is if someone is symptomatic, the employer can not only ask those questions, but the employer can actually require the employee to stay home and not run afoul of the EEOC or the Americans with Disabilities Act. Now, these are the next kind of pieces that, as we start looking at reopening, are some very good tools for employers to utilize. And one of those is we can take the employee's body temperature before they come into the workplace. What is now new is that as of last week, employers are now authorized to administer a COVID-19 test before permitting employees to enter the workplace. That's, again, that's those of us that watch the EEOC over the years, that's actually quite surprising. But again, employers may administer a COVID-19 test before permitting employees to enter the workplace. And the basis for that is because of a potential direct threat to other employees. And so the EEOC has determined now that COVID-19 is a potential direct threat to other employees, and the spread of it is a direct threat, and therefore an employer would be permitted to have a COVID-19 test before reopening or before allowing an employee back into the workplace. Now, we have to be very careful about confidentiality of this medical information, whether it be a COVID-19 test, or whether it is a fitness for duty return certificate, or whether it's merely a log of employee temperatures. The employer can retain that information, but that information must be kept confidential. It must be kept separate from the personnel file of the employee, and must be retained, again, separately from that regular, employee discipline, employee personnel file. So the confidentiality piece is pretty significant. The other piece of advice that was brand new and piece of guidance that was brand new was that the EEOC affirmatively stated that an employer may disclose the name of a positive COVID-19 test to a public health agency. Now, that had never been, outlined before by the EEOC, and there were concerns that disclosing that would be, a breach of confidentiality or a potential problem with the Americans with Disabilities Act. But now the EEOC has indicated that if you have an employee, if you administer these COVID-19 tests, and if you have an employee that tests positive for COVID-19, the employer is allowed to disclose that to a public health agency. So again, these are some increased tools for employers to think about and utilize as we start now to reopen the workplace. But it's, these are nice tools to help because it balances some of these shelter-in-order orders that are out there, shelter-in-place orders that are out there that are trying to impose further duties on employers than what otherwise might be required under federal law. And at least this gives us a clear framework from the EEOC as to how to avoid potential ADA claims down the road. Now, we do have to be careful. There is one piece, and one of the things that I've seen in a lot of these shelter-in-place orders is that we have, suggesting that employers must take further steps in order to protect high-risk employees. Now, the EEOC's position is that an employer cannot postpone a start date or withdraw a job offer to someone because they are 65 years old or pregnant or at some other high risk to COVID. They still would view that as potentially a discriminatory decision. What the EEOC does indicate we can do is we can provide a questionnaire to employees that has multiple, choices in a sense of, are you going to have problems returning to work based on the following? 1, public transportation needs. 2, school, children are at home. Or 3, you believe you may be in a high risk category. And then have them check that box. The EEOC is, and it's a little bit difficult here, they're saying we shouldn't be asking directly if they are in a high-risk category for, potential age or disability discrimination issues. But instead, we should be asking employees, or we can ask employees to self-disclose if they believe they're in such a high-risk category, and then we, could address it that way. So that's the piece that is still quite difficult for us to balance between these shelter-in-place orders that are requiring us to take extra precautions related to high risk and the EEOC guidance that says we shouldn't be necessarily directly asking about that information. So I think our best advice is to utilize the temperature testing and utilize the COVID-19 testing symptoms questions to protect, and then we can say that's how we are protecting our high-risk folks, is we're taking these additional measures. So that's the latest from the EEOC. Again, quite a expect in the past, but again, there you go. There's some outlines there, and you should, as you're looking to reopen, thoughtfully put into place a reopening sort of memo or outline or chronological order that just contemplates some of these things, including the potential temperature or COVID-19 testing. And with that, I'll turn it back over to you, Kim, or to Jay. I'm not sure who's going next.
Thank you, Brian. Jay, I think it's up to you.
Thanks, Kim. It's my pleasure. Everyone's Jay DeVoy from Las Vegas. I'm going to be speaking about 2 things that came down last week. The first came down on April 21st. It's some explanation from the Centers for Medicare and Medicaid Services regarding the blanket waivers to the Stearic Law that were previously issued. And then some other guidance came down from the Office of the Inspector General from the Department of Health and Human Services on Friday, April 24th. And I think that's actually very interesting because it provides an expedited way to obtain FAQ information and feedback almost in real time from the Office of Inspector General without the protracted wait and costs of the advisory opinion procedure, and I'll get to that in a moment. First and foremost, which is more technical, is the explanatory guidance to the Stearic Law blanket waivers that were previously issued on March 30th, 2020. And the guidance on this issue, again, came out on April 21st. It's about 5.5 pages. It's actually fairly dense. And I think one of the most interesting things within it is on the bottom of the first page, where it indicates that the Secretary for the Department of Health and Human Services will be engaged with the Department of Justice before any kind of enforcement actions are taken or before any kind of QTAM actions are taken up regarding the application of Stearic Law during this time while these blanket waivers were in effect. So I think that throws a blanket on the idea of the relator's bar, that there's going to be this kind of buffet of activity that's going to be available to them on the basis of confusion about how these blanket waivers were applied. And I think that's a recognition of the fact that the blanket waivers are still being put into effect. The blanket waivers and their exact scope are still being navigated by hospitals and other entities such as DHS providers. And I think also the bigger issue is that the waivers still need to be harmonized with the anti-kickback statute. There's been some activity to that end, and we'll talk about that in a little bit with the OIG guidance and where the two are in tandem. But it seems like CMS, in looking at this explanatory guidance, has taken a broad view of how the blanket waivers would apply, but it's not a limitless view. And it ties very much in with prior guidance on the relevant exemptions and exceptions that are discussed and expanded within the blanket waivers. So first and foremost, going through these blanket waivers, the first one is a piece of guidance reminding everyone that the non-waived portions of Stearic Law are still in effect. So the blanket waivers apply for COVID-19 treatments, and the specific blanket waivers that were issued, namely number 1 through 17, 1 through 18, there were a significant number of them that were issued. The blanket waivers only apply as far as they're written. It doesn't waive any other requirements under Stearic Law. It doesn't broaden any other kind of exemptions or exceptions. And for that reason, it's important to remember that the term blanket waiver is a little bit deceptive. It's limited to what's spelled out in the waiver itself, and it's important to go back and look at those waivers that were issued on March 30th, because beyond the scope of what's actually within that document, there are not waivers that are issued. Now, within those waivers, there are certain things that require clarification, which is the basis for this explanatory guidance. But aside from that, it's not a permanent or temporary or complete moratorium on Stearic Law and its requirements. It just is designed to provide a handful of circumstances that facilitate hospital and physician response to COVID-19. And even then, they're not unlimited. And as we're going to discuss in a moment, there's been some confusion about how these would apply. For example, the next topic that's discussed within the CMS guidance has to do with the amendment of compensation arrangements and what the consequence for that would be after the end of the blanket waivers, and those are lifted, generally corresponding with the end of the COVID-19 pandemic, although no firm timeline has been given for the lifting of the blanket waivers by CMS. For example, if a physician is given additional compensation to be present at the hospital, and basically the equivalent of hazard pay for being potentially subject to increased risk of exposure to COVID-19, which is we're seeing more and more, the consequences of are determined by the amount of exposure and the viral load that one is exposed to. The normal rule under Stearic Law is that once a contract is amended, to the extent it can be within the first 12 months, once it is amended, those terms have to continue in effect for 12 months. And what the guidance from CMS indicates is that that does not necessarily apply anymore. Now, at the end of the blanket waiver period, the contract can be amended down to its original terms and remove that additional compensation, or any excess compensation could be treated as a separate agreement that terminates within that time frame for additional services rendered. And in that case, it would satisfy other blanket waivers or even comply with the terms of Stearic that weren't waived during this time period. The next topic that's discussed is the applicability of blanket waivers to indirect compensation arrangements. And the question that came up was whether the blanket waivers would apply to indirect arrangements between a family member and a physician and the referral of or potential referral of designated health services. And what is significant here is that CMS reminded readers that a lot of these indirect compensation agreements do not fall within the scope of Stearic and do not require a waiver because they're not they're not contemplated within the scope of the statute and its regulations to begin with. And this is sometimes confusing, and it's something that Kim Stanger and I have discussed at some length in the last few weeks as well. That just because there are certain relationships that happen where there is a physician who might be a contractor of a group practice but not be a member of it, and whether they would get the benefit of certain get the benefit of standing in the shoes of the group practice and avail himself or herself of an exception that applies to the group practice. And the reality is that that is something that is either contemplated or it's beyond the scope of Stearic, and there's no requirement for it to fit within an exception because it's not something that constitutes prohibited activity, and it is sometimes something that wouldn't require a waiver. But to the extent that there is indirect compensation that is not waived by the blanket waivers, and it is something that is otherwise covered and prohibited by Stearic, there is a provision that the affected individual or group can apply for a specific waiver for that situation. And given the circumstances with COVID-19, it likely would be expedited. Depending on the facts and circumstances, it depends on whether CMS would grant it, but it's not a foreclosing of any potential waivers being granted. This guidance is very helpful to reaffirm that there are situations that are just beyond the scope of Stearic and don't necessarily need to fit within a blanket waiver, but to the extent that there is a circumstance involving an arrangement for indirect compensation that falls within Stearic and isn't addressed by a blanket waiver, the physician, hospital, or DHS entity that's affected can still apply for a waiver for that specific relationship during the crisis period. One of the other topics that comes up in the explanatory guidance is the repayment options for loans between a DHS entity and a physician. This is a topic that came up a lot within the blanket waivers and the subject of giving loans at more favorable interest rates or otherwise giving loans on terms that were very favorable to the physician or to the other entity that had to make repayments of it. And one of the topics that came up that CMS felt the need to address is the idea of the physician repaying the loan in kind, which is through services rather than through money, or the loan being forgiven. The explanatory guidance doesn't specifically address the issue of a loan being forgiven, just discusses it being repaid through in-kind services. So although the guidance addresses the fact that it received questions about a loan being forgiven, the response that was given largely addressed in-kind services to repay the loan and discussed numerous ways that that could be done, such as, for example, in medically underserved areas, the CMS views the physician being in the area as a benefit to the community itself, which is why CMS authorizes certain retention payments by a hospital or by a hospital to a physician or to a group practice to continue to practice in that area. And to that end, CMS takes the view that in certain circumstances, the physician or the group continuing to provide services in an area is the in-kind compensation that would warrant repayment or constitute repayment of the loan. But to that end, the repayment terms of the loan are not necessarily considered part of the blanket waivers that were given. So any kind of in-kind satisfaction of the loan will still need to comply with fair market value and commercial reasonableness standards. So although the loan terms can still be more favorable than they would be otherwise, the repayment of it still has to make sense, reflect fair market value, and be commercially reasonable. It's not something where a physician or a group practice can provide services for one day and they have that forgive about $1 million in debt, just to use an extreme example. Another topic that came up were the questions of amounts that were due at the end of the emergency period and when the blanket waivers are lifted. One of the concerns that came up were if payments had to be made or if payments were still due outside of the blanket waiver period, and if paying according to those terms after the blanket waivers were lifted, such as if an invoice was received late or if payment obligations extended beyond the end of that term, if making payments based upon blanket waivers after the expiration of that period would be in violation of Stearic Law. And the answer to this was a pretty resounding no, and CMS indicated that any kind of payments made after the expiration of that period would still be compliant with the law and not constitute a violation of Stearic. The reason for that being is basically that even though the payment might be received after the end of the blanket waiver period, the agreement or the arrangement was entered into or was modified in accordance with the blanket waivers during the period that was effective. So making payments pursuant to an agreement when it was valid even if the payment is made outside of that blanket waiver period, is still going to be permitted. And then finally, there was a very technical point that came up that CMS wanted to speak to, which has to do with recruitment arrangements with income guarantees and whether the income guarantee could be increased during the COVID-19 period. The answer was generally no. And the reason for that was that CMS viewed relocation payments as being the basis for the person, the physician or the physician group to relocate, especially to a medically underserved area. And that was the payment in and of itself. Increasing it after the fact didn't make any sense in CMS's view because the payment had already been made for relocation. And increasing that payment would not credibly be for relocation, would be for other services. So to that end, there are other arrangements that can be made, such as a rent reduction or a loan, that are covered by the blanket waivers, and those can be extended to physicians or to physician groups to address any kind of economic insecurity or disruption to their business that they might be experiencing as a result of COVID-19. But making increases to amounts that should have been fixed as part of recruitment and income guarantees to that is something that CMS would not allow, but did illustrate other areas of the law that could be invoked, and especially the blanket waivers that could be used to reach the same outcome without implicating the income guarantees as part of the relocation agreement. Turning now to the OIG's administrative enforcement authorities to arrangements directly connected to the coronavirus disease 2019 public health emergency and the frequently asked questions file that was last updated on April 24th, 2020. This is something I discussed at the beginning of my segment. This is separate from and designed to be a bit more responsive than and more interactive than the advisory opinion process. As reflected on the OIG's website, this is not a replacement for the advisory opinion process. The advisory opinion process is still ongoing, and the advisory opinion process has to do with things that are not related to COVID-19, but due to the need for immediate responses regarding COVID-19, a separate email account has been set up for that specific topic. It is OIG compliance suggestions at oig.hhs.gov if there are any questions that are going to be submitted there. Similar to a advisory opinion, OIG requests a submission that includes sufficient facts to allow for understanding of the key parties in terms of the arrangement at issue, but these are not as extensive as the certifications and other information required for a full and formal advisory opinion. Now, to that end, the advisory opinions and the kind of advice that OIG might give are only binding upon the parties that are that submit it, that receive that actual determination from the OIG and have the specific facts in front of it. It's not binding on any other parties. So if you and I were to look at it, if we didn't submit this request to OIG, we cannot necessarily hide behind the OIG's opinions as a defense to whatever conduct was entered into or was committed, just because that information, that specific relationship with those specific parties was not submitted to OIG for its blessing or its opinion, but it's still illustrative as to the direction that OIG is taking in terms of enforcement priorities and how it views things in the current circumstance. To that end, a lot of the questions that have been answered to date have been set forth in the website in responses that can be expanded and reviewed there. And looking at a lot of these, it's a wide range of topics that are addressed from behavioral health to oncology to skilled nursing facilities and hospitals. So it really covers at this point the continuum of skills and services that will be necessary during this time and could be most impacted by what is happening in the current public health crisis. And this database of knowledge will grow, and these responses will increase over time as the OIG has time to receive and process more requests for clarification. The answers, though, are pretty consistent, and frankly, as somebody who's been following these advisory opinions for many years, surprising in terms of the leniency that's being granted to practitioners and to facilities in terms of what is being permitted during this time. It's not as formal as an exercise of discretion against enforcement of these laws, but it is interesting to look at these and see where OIG is viewing its administrative and enforcement priorities under both the False Claims Act and the Anti-Kickback Statute and the Civil Monetary Penalties Law. in terms of where it would seek to enforce those laws and seek some kind of redress from providers or other facilities that might be implicated in this. For example, mental health practitioners are permitted to assist their patients in paying for their cell phones, normally a circumstance that would raise some serious eyebrows in terms of facilitating somebody consuming medical services and making a payment to somebody to drive up the costs and the consumption of medical care. And OIG notes that there are ways that this relationship can be made to work within the existing safe harbors for it. But under this circumstance, because of the importance of mental health at this time, OIG has indicated that they see no problem with this during the existence of the COVID-19 emergency. Similarly, OIG passed and gave its approval to an arrangement where an oncology group that has a closed office and needs to transport patients who are undergoing treatment to a different facility, providing transportation to them to that alternate facility to continue their treatment. And then other examples are where a skilled nursing facility can use the services of physicians and other healthcare providers for free, something that normally raises a major red flag with the Office for Inspector General and requires significant mitigating factors to find that there's not a high likelihood of fraud and abuse. In this circumstance, because of COVID-19, the Office for Inspector General said that there's a low likelihood of fraud and abuse, even though the provision of free services is pretty much prima facie below fair market value. And in this circumstance, they have indicated that the OIG does not necessarily see an issue with it during the COVID-19 outbreak, although that is not something that they would necessarily find at any other time and not a position that I think they would consistently take after the passing of the pandemic. And then finally, a similar analysis issues with a hospital providing access to a HIPAA-compliant web-based telehealth platform to independent physicians on medical staff to provide medically necessary telehealth services during the COVID-19 pandemic response period. The provision of free services by a hospital to a physician is something that is also covered by one of the blanket Stearic waivers that we were just discussing, and which were, again, issued on March 30th, 2020, and we've discussed in the prior webinar. So this is an instance where OIG and CMS have largely lined up in terms of permitting this kind of service. Again, there's no blanket allowance under the Stearic Law for a hospital to give services to a physician, but in terms of the incidental and other benefits that a hospital can provide a physician, the blanket waivers relax those standards. So this is a situation where the OIG has indicated that while normally they would take a very dim view of a hospital providing something for free to a physician, here, if it's being used in connection with COVID-19, they don't necessarily see the issue, and it also threads the needle, or can be done in a way that would thread the needle with one of the blanket waivers that were issued pursuant to Stearic. And this is an area where the OIG has been more accommodating than the Stearic explanatory guidance that we just went over, which is an interesting thing to see given the increased flexibility of the anti-kickback statute, given its ability to pursue activities that were taken knowingly and willfully, and where any one purpose of the payment or activity was to obtain healthcare referrals. So it's interesting to observe this trend, and I anticipate that we will see more guidance from the OIG on this front. And I also would not be surprised if in the next 2 weeks we saw more explanatory guidance from the Centers for Medicare and Medicaid Services regarding the blanket waivers to the Stearic Law that were issued in late March. And that concludes everything I have to say. It was a lot. I appreciate everyone's patience. And Kim, back to you. Well, Tim, Brian, anything that you'd like to add?
This is Brian. No, I think, again, there's a lot for folks to digest. And I think just the best advice that anyone can have right now is to think thoughtfully about what we're doing, try to be guided by faith, because we're going to have a lot of these things that continue to change daily. And so employers, it's important to act in good faith and kind of document the steps that we've taken to act in good faith.
All right, well, I think that's about our time. Hearing nothing more, I appreciate everyone being here today. Thank you for your time and attention. If you have any follow-up questions, please don't hesitate to follow up with any one of us. We look forward to hearing from you and responding to any concerns that you might have. And we look forward to speaking with you again in the future. I know we have more webinars coming up. including about changes in telehealth and other issues that are constantly evolving in this environment. If there are any suggestions for future topics, again, we welcome those as well, and appreciate you joining us today.